Thank you, Dr. Kennis, for that great talk on diagnosis. And I really agree that it's important really to know what you're dealing with. And I have to say, as a GP, it still amazes me the numbers of women that come that have just accepted bad headaches around the time of their periods and not really known that what they're dealing with is migraine. There's something about knowledge, something about the diagnosis that helps you to be able to tackle the problem. So I'm going to share my screen with you now and introduce my talk. And the Migraine Trust have asked me, I'm delighted to be speaking today. Migraine Trust have asked me to speak on migraine and hormones. So my name is Dr. Louise Rusk. I'm a specialist GP like Dr. Kennis, and I come from Belfast in Northern Ireland. I work mostly as a GP in this practice in Inner East Belfast. It's a big practice within a health centre with a number of other practices. So we're in East Belfast, and right behind us is this beautiful statue of Aslan, who you'll know is from the Chronicles of Narnia that was written by C.S. Lewis, who was born and grew up in Belfast. And the other thing that we are sort of famous for is the Titanic, which was built in Harland and Wolff shipyards. And we can see these cranes actually from one of the consulting rooms out to the back of the practice. And as they say, she was okay when she left Belfast. But just to get to me as a GP with specialist interest in headache, I work in the neurology department in a local district general hospital, and I'm there for a session a week where most of my working week is working as a GP. So that's where the context with which I am coming to you with patients or with advice about hormones and migraine. And interestingly, when it comes to diagnosis, I see lots of women who talk about having really bad headaches around their period, and they say, no, it's not migraine, or I got migraine when I was in my teens, and this is not it. This is just a really bad headache, and then migraine medications don't work for it. So actually, it's important to know that the diagnosis is actually migraine, to use the correct treatment for it. So why do hormones make any difference to migraine? People want to know, is it periods that cause my headaches? If I get rid of those, can I not have headaches? How can I treat those ones that are bad around the time of the month? What happens if I get pregnant, and what should I expect around the menopause? A huge impact of migraine. It is predominantly a female condition, and in fact it's the fourth leading cause of disability in women. And as I'm going to come on to, it actually tends to affect women mostly from the teens right through 20s, 30s, 40s into the menopause. So if you think about it, that's a time when girls are trying to study for A levels and make their choices about where they're going to work, like what kind of university or degree, if they're going to go to university, or if they're going to go on and study further or take an apprenticeship. And if you're going to do something like care in the community, for example, the shift work can just be really difficult. So it really impacts on people's choices. And then right through, if you think there are many women who are trying to juggle raising young families with work and the stresses that brings. And of course, we all know that impacts upon migraine. And I'm sure there are people listening this morning that are like me and having to juggle work with homeschooling children at the moment. So it's, it's a difficult sort of stage of life if you're somebody who suffers with migraine. So what is it about that XX factor, that thing that we have? Is it a man's world? So the X factor, as an XX factor, I suppose I'm saying that's women. What makes it worse for us? Well, there's a lot of fluctuation of hormones going on for women. And that happens at the start of periods. That's called the menarche, and that's a time when the body is really getting to grips with the hormones. There's a real fluctuation which is resulting in some girls in a real flurry of headaches. Um, and then, of course, as that settles down into regular periods, women can notice headaches around the time of their periods, and then hormones change again if there's pregnancy. And then for up to about 10 years leading up to menopause, the hormones can fluctuate and affect headaches as well as lots of other symptoms, as you all know. And then, of course, it's not just our own natural hormones, but those that we take as well. So hormonal contraception can affect your headaches. HRT can do that. And there are some small studies, but increasing research on the hormonal treatments for gender transition and the effect on headaches. So I hope you don't mind if I show you a couple of graphs. You may or may not be used to looking at graphs, but I just wanted to show this because it does show that there is one stage of life where it's more common for migraine to be diagnosed in males than in females, and that's actually in early childhood. So if you look at this graph, the vertical line, which is the line that's going up on the side, that's numbers, and it starts at low numbers and goes away up to high numbers. And what it's looking at is the numbers of people that are diagnosed with migraine. And then the line along the bottom looks at age of onset, and you can see that it starts at 0 and goes through 5, 10, 15, 20, 25, 30. So it's really interesting to see the white dots there, that represents female, and the black dots represents male. And there at the age of 5, it's actually more common for little boys to be diagnosed with migraine than girls. But you can see, and that kind of gradually goes up and it peaks around the age of 10. But you can see if you look at the girl part of this graph that actually, although it's much less common in those very early years, that whenever we're hitting that puberty stage, say up at 10, going on up into the teens, that there's a really big increase in the new diagnosis of migraine. And you can see that when you look back down at that boy part of the graph, that really after the age of 20, 25, there are much lower new diagnosis of migraine. And then what happens after adolescence? So we've got a picture of my daughter here with a little dusting of snow that we had there recently, and she's on the one side, and I don't know any of the ladies on the other side, but this is what happens really between adolescence and menopause. So this is a different thing. This is called prevalence, and this is looking at the amount of people. So it's it's not only the people who are diagnosed with migraine, but those who have and are experiencing migraine through these ages. So if you look at the dark line, so again we've got numbers up the vertical, and this time we're looking from 15 to 75 along the bottom line. If you look at the dark line, that's what happens in women, and the light line is what happens in men. And you can see that with men and women, the peak is sort of in that middle at 30 to 39 sort of stage, but there's a much greater number of women experiencing migraine than in men. So what about hormone, or what about pregnancy? So sometimes what happens in my GP practice is I would get a patient who's been doing really well with her headaches, hasn't had for ages, becomes pregnant, and then she actually contacts, says, oh my goodness, my headaches are awful. I just think this pregnancy is going to be awful. What should I do? And that's a really common consultation with migraine patients, but it can be a really positive one too, because the fear is there that how are you going to cope with no sleep, and as bump gets bigger and everything, what way is this pregnancy going to be awful? But I think it's really helpful for women to know that actually Migraine, whilst it will tend to worsen for many people in the first trimester, that's the first 3 months, first 12 weeks, that for the vast majority of women, it improves in the second and the third. And so really what that first 12 weeks is about, and really, I suppose they tend to be getting worse around 6, 7, 8 weeks. And if you think about it, you've really only got another few weeks to go of bad headaches. So in that time, it's very important to be trying to do self-care. That's looking, ensuring that your sleep pattern is regular, eating regularly, not going long periods in work without a meal, taking fluid, and that you try not to make too much expectations of yourself, with the hope that in the rest of pregnancy that things will improve. Um, and it can worsen after the baby's born. And women want to know, what can I take? Well, actually, I can't really manage without anything. And there are a couple of things that are well known. People will tend to take paracetamol and find that it doesn't really work for migraine, but they're often not keen to take anything else. But I often, if in most women, they don't want to take anything, but for some who have to, for either work or keeping going for their other children or whatever, and they really want to take something, that we will have a balanced conversation about the safety of some of the migraine drugs. And there's a very useful website, the best use of medicines in pregnancy, and that is, pulls together a lot of the data on safety, and that can be looked at actually for most medications, and looks at safety data. So it's really patient orientated, and you can have a read at that if there's something in particular you want to look at. And in terms of the triptans, which are the most migraine specific medications, sumatriptan is the one with the most safety data. But certainly if you're in that situation, I would be looking at that website and going and having a chat with that information to the GP. So hormones, well, I say, well, we all know that there are lots of different hormones in the body. Why don't they all affect, or do they all affect headaches? And do you know what? They probably all affect headaches to a certain degree, and some more than others. We know that there are other ones called prostaglandins, which can fluctuate around periods, and they can certainly affect headaches. But yes, I've just listed a few sort of hormones, but estrogen is a sex hormone that's important for the development of the reproductive system and the or what we call secondary sexual characteristics such as breast development, etc. But estrogen receptors are found all through the body, and anybody who's listening who has gone through menopause and had difficult symptoms with that will know what some of those are. So they're found in, skin and hair, and the strength of your pelvic muscles. They're also found in the vaginal wall and responsible for vaginal lubrication, etc., etc. But estrogen is something that fluctuates quite a lot in women's lives. So it fluctuates during those times that I mentioned about periods and pregnancy. But in periods, now this graph is possibly a step too far, but what I want to point out is that if you just look at this, you can see that there's a bit of this going on. So it's no wonder that at times women can feel a bit off, at the time of ovulation and at the time of their period. But estrogen is the one there with the long, dark dotted lines, and there's a peak around ovulation and it drops, and then it peaks and then it drops again. And it's thought that that sort of drop in estrogen in some women can be a real trigger for their migraine. So migraine attacks associated with period, are they really any different? Well, they are. And I know that for some of my patients, they would say that their migraine attacks that they get during the months are different from those that they get from during their period. And so most women with migraine will notice a relationship with their migraine attacks and their period. It's very rare, but some women will say that their headaches are only triggered by menstruation and nothing else, that their migraine attacks are. Menstrually related migraine refers to headaches that occur between 2 days before bleeding and 3 days after that first day of menstruation. And that has to be in at least 2 out of 3 cycles. And you really need to diary to be able to show that to yourself as well as to the GP. But are they different? Yes. Migraine attacks at the time of your period tend to be longer, they tend to be more severe, and they tend to be more difficult to treat. So the usual medications you would go for don't always work as well in the migraine. But on the other hand, they can be predictable. So what can you do about it? I would say look at the pattern of your headaches and a diary over a few months. So the Migraine Trust has a good diary. I would do it over 3, 4, 5 months just to really get a sense of what's going on around that. And it also helps you to say, well, what else was going on in my life at that time? What was my sleep like? Was there some other sort of stressors? And then I would say be prepared, have your rescue plan. That's your treatment that you take for migraine, because the earlier you can get that in the migraine attack, the better and the more responsive it will be, even in a menstrual migraine. Self-care is really important around this time. I mean, women do tend to just get on with it. And in fact, our practice nurse was then talking to me about, I was telling her I was writing this talk, and she said, oh, I never did anything about that. And we talked about, she gave me permission to share this, but we talked about headaches around periods, maybe 4 or 5 months ago, and I had made some suggestions to her, and she said, "You just don't have time, we just don't really prioritize and But then what happens is that you get those few days which feel absolutely awful. But yeah, so self-care, prioritizing yourself, looking at your pattern and trying to get a good plan is important. Some women do benefit from short-term preventative treatment. That's the women who really only get it around their period. And that has to be prescribed by a GP. And there are specific medications that are good for that, specific triptan medications. So normally for use of triptan, you only use it when you feel a headache coming on. But for some women with these very specific migraine, they can benefit from taking triptan medication for a couple of days before and a couple of days after the period starts. There are pros and cons to that. A lot of women don't like having to think about and remember to take their preventative medication every single month, and focusing on it can sometimes make it worse. But remember that if you have disabling headaches at other times of time of the month, so if you're getting more than 4 days in a month that are affected by migraine, then a migraine preventative might be for you. So just to remind you about rescue treatment, and some of you will have seen this slide in the Migraine Trust International Symposium Patient Day. So the rescue treatments can be a combination of these medications, so painkillers, anti-inflammatories, triptans, and an anti-sickness. And what you might find is that for your headaches during the month, that you don't actually need all of these, or that a certain combination works for you. But you might find that you need to add another one in at the time of your menstrual migraine. For example, anti-sickness medication prescribed by your GP can actually improve the benefit of the other migraine rescue medications, even if you don't experience sickness as part of your migraine. We really recommend avoiding codeine because of the risk of medication overuse headache. And remember that rescue treatment in general is supposed to be no more than 8 to 10 days a month to avoid medication overuse headache. But what often happens for menstrually related migraine is that they'll get a few days in a row where they're having to use it, and then maybe weeks that they don't. Preventative treatments, just a reminder, these are something that you take every day. And what this does is something that can make your migraine attacks less frequent, shorter, and less severe. And what that might result in with the headaches, the bad headaches around your period, is that they're actually more responsive to the rescue treatment. But don't forget, for both menstrual migraine, menstrually related migraine, and the migraine that's around your menopause, it's all so important to keep that balance. The brain likes, migraine brain really likes balance. It likes routine. It kind of likes predictability. So it's keeping a good regular sleep routine, trying to avoid missing meals, points of stress, trying to not ask too much of yourself in the rest of your life if it's at all possible. And hormone levels are just another trigger into this for people with migraine. So what about hormones and contraception? Well, going back to what Dr. Kennis was saying earlier, correct diagnosis of the type of migraine is actually really important when it comes to contraception, because some forms are not allowed if you have migraine with aura. So the combined pill, the estrogen containing pill, so that's the one that you take for 21 days often and have the 7-day break in the old traditional way of taking it. That's the one that you should not take if you have or have had aura. And that is because of a slightly increased risk of stroke with that combination. And indeed, if you do start to get an increase in your headaches when you start to take the combined pill, then you should go back and speak to your GP about an alternative. On the other hand, if you're somebody who doesn't get any, if you've migraine without aura, you've been successfully taking the pill for some time, and you've noticed a pattern that actually you don't get any headaches during the 21 days whenever you're taking the pill, but then you get really bad headaches in those 7-day break, that can actually be because of the withdrawal of the estrogen, the drop of the estrogen in your body. And it may come as a surprise to some of you, but what we can recommend in that case is actually that you take your pill back to back, so you don't take the break. And that in some women can eliminate that headache that happens only in the pill-free period. Now, if you're going to do that, it is important to talk to your GP about it, just because the different types of pills have different levels of estrogen, and you want to have the one with the lowest form of estrogen if you're going to be taking it continuously. So note that if you're somebody who gets migraine with aura, that the progesterone only methods are recommended. That's the progesterone only pill. That's one that you take every day, desogestrel, commonly known as Serel, Cerazette, or the Mirena coil, or the injectable contraception, the Depo Provera. Those are progesterone only. And so in women in whom there is no bleeding with those progesterone only contraceptions, they may find actually that this really helps with their headaches too. So just want to do a little bit of signposting here. BASH, the British Association for the Study of Headache, have created a fantastic resource for doctors and for headache sufferers. And if you click into that's the website. If you click into the headache sufferers, you find lots of little useful videos on medications, and specifically there are some videos and information leaflets on menstrual migraine, migraine in pregnancy, and breastfeeding. But I want, before we finish, to just touch on migraine and the menopause. So this is a graph that I showed you earlier. So what happens there again is that in that lead up to the menopause, there can be a real fluctuation in the hormones. Periods can be all over the place, flushes, and night sweats can be problematic long before the periods actually stop. And for women who have migraine, they often notice that there's an increase in their migraine attacks too. And it's interesting that in the women that have flushes, that HRT can really help women's headaches as well as those other symptoms as well. But women who are coming to talk about hormones have been told almost through their whole reproductive life, you can't have the combined oral contraceptive pill, you've got migraine with aura it'll give you a stroke. This kind of has been drilled into people. But HRT is different because unlike in contraception, Aura doesn't restrict the use of our normal body levels of estradiol, and that's what's in HRT. But what is better and what results in less fluctuations for women with migraine are the transdermal methods. That's the gel that can be put on the skin, or more commonly the estrogen patch. The really important thing though is, if you are going to have a patch, that you need to have protection for your womb, unless you have had a hysterectomy. And so that can be in the form of a Mirena coil, or in tablets, progesterone. So again, I'm going to do a little bit of signposting. So for really one of the gurus in hormones in migraine is Professor Anne McGregor, and some of you may have heard of her. And she did a fantastic fact sheet for doctors, actually, on the British Menopause Society. And if you, as women with migraine, want to have information too, you can look at that, but you can also look on the Women's Health Concern for her fact sheet on migraine and HRT for women. And there is another charity called the National Migraine Centre, who does some educational podcasts for people who are affected by migraine. They're run by GPs with specialist interests who are kind of like what Dr. Kenneth and I do, and they record podcasts that are on lots of platforms, including Apple and Spotify, etc. But if you have a look at, I think it was last season, it was 2 series ago. So it's the first episode of series 2. Professor McGregor has done a podcast with them on hormones and migraine, if you're wanting to know some more. And indeed, on her own migraine trust, she's done a brilliant blog there recently on menstrual migraine. So I hope that's answered some of your questions about hormones with migraine. And Dr. Kenneth, she speaks to other doctors about hormones in migraine, and she teaches her colleagues. And both of us are very happy now to try and answer as many questions as we can during this live question and answer session. Thank you.